Hello and welcome to Gwinnett County Public Library. My name is Amy Perry and I'm an adult services specialist here at the library. Thank you for joining our program, Piecing Together American Healthcare. We are excited to have Dr. Ilana Yurkiewicz join us to speak about her book, Fragmented, a doctor's request to piece together American healthcare. Dr. Yurkiewicz is an oncologist and internal medicine physician on the faculty at Stanford University. She is also a science journalist with articles published in The Atlantic, Scientific American, and the Best American Science and Nature Writing, among many others. Please welcome Dr. Yurkiewicz.
Thank you, Amy, for inviting me, and it's great to be here.
Yes, thank you. We're so excited to have you and discuss your book and how you came about to writing it and what the importance of it to our American audience. Not only are you a physician, a very busy physician, but you somehow find the time to write. So could you kind of tell us how you became interested in writing medical journalism?
Sure. So I actually developed my careers in medicine and my careers in science journalism in parallel. So way back in college, I knew I wanted to be a doctor. I knew I wanted to go to medical school. But at the same time, I felt this itch to write for public audiences. And I think in retrospect, the reason is that it's actually the same skills at play when you're in the hospital or exam room or writing, which is that I really enjoyed taking complex science or medical information and breaking it down so that everyday people could understand it, find it interesting and accessible, and I could use it actually to help their lives. And so I ended up pursuing both. I did go to medical school and then residency and fellowship and became an attending physician. And then at the same time, for the last 10 plus years, I've been writing science and medicine articles, and this is my first book.
Okay, thank you. So for maybe some of our viewers who haven't had the opportunity to read Fragmented, can you give us a quick overview of it?
Yes. So Fragmented makes the case from my for my almost a decade of being a practicing physician in the trenches, that the greatest issue underlying American healthcare is that the patient's story is fragmented into discrete pieces by design. And what I mean by that is that when you come to see a doctor or you come into the hospital, anyone comes in, you expect that your physician or healthcare worker knows your full story, has access to a full set of medical records about you, and can make decisions, sometimes life or death decisions, based on a set of information that they have about you at hand. And practicing medicine for all of this time, I realized very, very deeply that this just isn't the case. As doctors and healthcare workers, we are constantly working in a state of being partially blindfolded to the full details of patients' stories. And I believe there's incredible fallout as a result. And there's two major categories of fallout. One is that everyone is burdened now with stitching the pieces of their own medical story together. Patients are burdened when they're sick. Their loved ones are burdened when they want to be focusing on helping their loved ones get through illness. And healthcare workers are burdened with bureaucratic and administrative tasks of gluing these pieces together when they also want to be focused on sickness and healing. And then the second fallout is errors and near misses. I write in the book about problems that result in healthcare that can cascade as a result of doctors not knowing the full details of the medical story. And these can range from repeating things like tests and procedures that have already been done, but they just don't have access to, as well as errors of omission, where you miss a diagnosis or you miss a suboptimal you pick a suboptimal treatment plan just because you're grasping at these pieces of a patient's narrative.
Right. And I think so many people can probably relate to having some of those experiences. I know one of my I've had several of them in being a caregiver for my sons and my husband, but one in particular that sticks out in my mind is that the medical records of my sons, they went to go get a flu shot, a routine flu shot several years ago, and suddenly we were denied one. So I have twin sons, and one son was denied a flu shot. And this was very shocking to me, and I couldn't understand why was the doctor's office denying the other son the flu shot. And we later found out that the medical records had been merged together. So they only had a record of one of my sons because there was a glitch in the system that didn't recognize same birth dates, which, you know, in the 2000s, you don't think technology would have such a minor glitch that would catch this problem. And luckily we were able to resolve it, but it did take a little bit of time. Insurance had billed us twice, but the fragment portion of the medical record keeping had failed us. And so I believe this is a common thing, and I'm glad you wrote a book about it and is sharing it with the public of how the problem has started and maybe how we can resolve it as well.
Thank you for sharing that story. It's a perfect example of what everyone goes through every day. I think every single person has a story just like that. And I would say there was actually two good things in your story. One is that there was you to advocate for your sons and to recognize the error. Now imagine if someone doesn't have that person in their lives, or they can't be that person, and an error might result, and they wouldn't get their flu shot that they're due for. And then the second thing, you know, is I wouldn't say a flu shot is not, I don't want to call any medical procedure minor, but kind of on the spectrum of things. You know, imagine if it were a much, you know, more dire situation and someone couldn't advocate for themselves. And I think when people come into healthcare, there's this expectation, as there should be, you know, that the system is fully functional from a technological standpoint, that if something was done, there would be a record of it. And it's often shocking to patients when they realize that they have to be their own advocate, and that these little things can slip through the cracks, and that they have to be constantly checking and making sure that what their healthcare providers are telling them are accurate based on the information that they have in their system at hand. And so I felt so compelled to write this book because of what you shared, because it's so universal and everyone has a story, but I wanted to put the language on this problem.
Right. And so how do you think in the US the healthcare system became fragmented? We know there are times when it seemed to be running smoothly, and then probably in the last decade, maybe 2 decades, there's really been a lot of talk of our system not being efficient. So in your opinion, where did you see it start to fall apart?
I think there's a few relevant time points, and one was in 2009, when the great shift from paper records to electronic medical charts began. So before 2009, most of your hospital or doctor's office records, like your flu shots, were kept on paper, and they were kept in binders, and they were kept in filing cabinets. And I want to be clear, that had its own problems, major problems. And I don't think we should go back to a world where we are writing things by hand, where sometimes as a doctor, I literally can't read another doctor's handwriting, and then I can't track something down in a filing cabinet. So in 2009, I think there was a very positive move in this country where Congress authorized and funded legislation. It was called the High-Tech Act, to try to convert paper records to electronic charts. And they tried to stimulate hospitals and doctors' offices nationwide to do this. However, there was a push to make the paper records go electronic, but there was no related push that these systems had to communicate with one another. So as a result, there were now there's hundreds of different electronic vendors that often operate in silos. So meaning you can, you know, see a doctor and then go see another doctor just up the street. But if they're in a different healthcare system and they use a different electronic vendor, those systems don't always communicate with one another. And so your records can vanish when you transfer from one healthcare facility to another. Um, Another related problem around that time was a couple years later, actually, it was in 2011, where the federal government had the CMS, which was also responsible for converting paper records to charts, authorized something called meaningful use, where they were trying to stimulate, again, all hospitals to go paperless, and they wanted to standardize this process. Again, this sounds like a good thing on paper. Standardization is good. Everybody should be doing the same thing. But they set this slew of metrics that hospitals had to meet in order to receive reimbursement for going paperless. The problem was this slew of metrics wasn't always clinically or medically significant, meaning doctors had to chart things like smoking status, family history, whether somebody was coming in for a simple cold or end-of-life care. And as a result, they had to chart this stuff over and over, and important findings got buried while kind of all of this meaningless clutter rose to the surface, to the point that now most doctors, or some doctors, kind of pejoratively dub meaningful use as meaningless abuse, because all of the important stuff got buried. And so what I want to emphasize too is that even if you're in one healthcare system and all of your data is technically there in that system, like we're not even talking about transferring, your data can still get lost just because your electronic medical record is so cluttered and it's disorganized and it's not written like a book with a beginning, a middle, and an end. And so doctors on the other side have to click through dozens of tabs just trying to track down these pieces of your narrative, and things can still go missing, even if everything is within one system.
Right. We definitely have the technology, but it's still not the most efficient, right? That, like you had mentioned several times in your book, of just doctors clicking, and when you click one feature and another, all the additional options open up, and then you click another, but the information might be hidden even further down there, making it inaccessible to insurance, the doctor, and the patient. So how do you think maybe I don't think you talked about this in the book, but with AI coming, is that a positive in a movement towards being more efficient with the data, or is that something too early to see, or what are your thoughts about AI?
Very too early to see, and I am skeptical about the idea of using technology to organize medical records to make them easier and more accessible for doctors, when the very problem was the technology in the first place.
Mm-hmm.
And again, I'm not saying that paper records were the solution. I think that was a worse situation. However, I want to emphasize that we actually had the technological capabilities in 2009 and 2011, at the time, to organize all of this information and make it easy and accessible for patients and their doctors to understand. And it didn't happen. It didn't happen because it wasn't necessarily a technological problem. It was a problem of incentives, and it was a problem of, who's at the decision-making table. Is it doctors and patients and their loved ones and other healthcare workers, or is it insurance companies and big healthcare organizations and big tech companies? And I believe, one of the root causes of this problem was that the right decision makers were not at the table. And so even though we had the technological capabilities, the electronic charts have become a mess. And so I think we face kind of that same decision making right now with AI, which is going to be who's at the table. And if it's big tech companies and well-meaning programmers, but well-meaning programmers who don't have clinical experience, and not doctors and healthcare workers and patients and their loved ones, the risk of AI is actually taking big data and fragmenting it even more, so that it actually creates more manual labor for doctors and patients to put the pieces together, because that is what has happened over the last decade. And so I think there is potential if it is used, in a very specific way, and there's a lot of thought given to how it's going to be used to organize information. But there's actually a big risk here of AI making information even more disorganized, increasing the manual labor that then burdens everybody in the healthcare system. And so I think now it's a great question, because now is the time to be giving it all of that upfront thought, so we don't get into a situation like we are now, where 10 years later, things have just spiraled to the point that I'll give an example that I cited a study in my book that an average shift in the ER, in the emergency room, doctors have to click 4,000 times. And I don't want to be in a situation in 10 years where that number is 12,000.
Yeah, I remember reading that and I was thinking, that's so true. Just even in simple things that we're doing every day with our computers or our phones, it's not just a quick look, it's a quick click and then click again and another click. So I definitely can understand a piece of how difficult that is, just to get to that information that is there. You just can't access it in a timely manner.
And I want to say that should be the easy part of medicine.
Right.
Hard enough. Making diagnoses is hard. Treating patients based on their individual characteristics is hard. The data collection and data entry is supposed to be the easy part.
Right. I like one of your sentences. I'm excuse me, I don't think I'm quoting it exactly, but in the book you said that the ironic twist to all of the computers and technology we have is that humans are needed, right?
Yeah.
Because there's so much, that humans are still needed, and needed even more so because it's just not accessible to the average person or to the medical care staff that needs to access it. So we need to be working with different colleges and universities, right? And here we have Georgia Tech. We need to be reaching out to them and making sure their students who are going into that can design, working with doctors and medical staff to have that mindset of how is it going to be accessible? Where do you line it up, right? To make those decisions.
The user has to be front and center. And who is the user? The user is not the software company. The user is the healthcare worker, and now the patient. I think there's been a big movement, again, in a positive direction, that now patients should have access to their medical charts. You are ultimately the keeper of your own medical story. This is something that I tell my patients over and over to empower them to advocate for themselves. And so those are the users.
Right. And I think that was my next question, is who ultimately owns the medical records? Is it the hospital? Is it the doctor? Is it the patient? Is it the insurance? Does everyone have a right to see them and view them without permission? How does that work?
Yes. So there are different laws in different states about who ultimately owns the medical record, where in some states, it's in most states, I would say, it's the healthcare organization actually that own your records. Many states then still don't have laws about who owns the medical records. But even in the states where healthcare organizations own the medical records, HIPAA also, since 1996, the Privacy Act says that you as a patient have a right to receive copies of those records upon request, with a few exceptions, such as psychotherapy notes. And so even though you might not own it, let's say in your state, you have the right to request it and receive it. And that process should also be very smooth, and it is not. So I talk in the book about how there was another study that somebody at Yale did, where she posed as her grandmother, looking for her own medical records. And she called up the medical records departments of 83 different hospitals and asked, how can I get my records? And the answers she got varied dramatically from different hospitals. For example, there's supposed to be just a flat fee of $6.50 to receive a full copy of your records, and she was cited costs up to $561.
Wow.
You're supposed to receive your records within 30 days upon request, with one 30-day extension, and some hospitals cited timeframes that were longer than that. You're also supposed to receive records in the format that you request, such as, I want it mailed to me in paper, I want it electronically on a flash drive. And she also got different answers about what they said they could do. And so I think now this has changed a little bit, in that many hospitals and doctors' offices have patient portals where your data is released to you in a much quicker way than waiting for a flash drive or a stack of papers in the mail. And that was a result of the Cures Act final rule, which was passed in 2021. So this is a relatively recent thing, where again you can pull up your phone or your computer and just sign into a patient portal and access your data. And I will say, I think that has been a very, very, very good move. I think there was a lot of controversy when this happened that I do talk about in the book, where some doctors kind of protested this move and said that releasing this data very quickly, instantaneously to patients is going to create undue anxiety. People are going to see their test results before we doctors have a chance to go over it with them. And then on the other side, patients were saying, well, no, I mean, this data is mine. No one's more invested in my own health than me. And kind of you doctors are too full of yourselves that you think that it's necessarily better for you to tell me bad news than for me to, let's say, pull it up at home on my couch in the privacy of my own home. And the sky has not fallen. This has happened now for a few years. Patient results are released with a few exceptions. In time frame, meaning that things like CT scans, MRIs, biopsies, often we do impose a little bit of a time lag, such as 2 weeks, so that the doctor does have a chance to make an appointment and go over test results with the patient. But I think ultimately it has been a positive move that we have moved away from data blocking with patients, because they are the very people the story's about, and they are ultimately the most important person, in this whole narrative.
And have you found any negative parts of having patients having access to the patient portal? Like, is it too much information for the average patient, or do they try to contact doctors more often because they have that information, or overall it's been a positive?
I think overall, net, it's been a very positive thing. There are certainly some patients that do get anxious about test results that crop up before they can go over them with their doctors, and maybe it's increased a little bit some of the messages I get. However, it's also increased other things that are very good, such as when I do a visit with a patient now, it feels a little bit more like a flipped classroom style in education, where somebody can come to the visit fully informed, like they know what their cholesterol is before the visit. And so then they're prepared and they have their questions and we can talk about it in a more meaningful way. And so I have found that the positives definitely outweigh the negatives. I also would add that one more positive is that in our fragmented system, doctors can miss things just because of everything I mentioned earlier, that they're just so overwhelmed with so much data. My biggest fear as a doctor is that something important is going to fall through the cracks, not because I missed it, but because the electronic system buried it somewhere, and that maybe there's a test result that, I just didn't see in a timely fashion. Now I know that my patients are looking. It's like an extra check and balance, because I trust that they will contact me if something is very off.
Mm-hmm. Yeah, I find with my insurance, having that patient portal is very helpful. And I'm sure it's similar to like with teaching. A lot of parents also have the parent portal at schools where they can see everything that their child is doing. And I'm sure that's maybe similar in that having that information is nice, and it can eliminate some multiple emails, because you have it right there. And then if you have questions, they're available to discuss further. If you didn't understand the test results or need more explanation, that they're still able to contact very easily as a teacher or as a doctor to respond to the questions.
I think it's a perfect analogy. I mean, I think it empowers the system to actually work as it should, which is that patients know their own health history, doctors know their health history, and then everyone, they can spend that time together, taking that conversation to the next level.
Right. And you mentioned the patient portal for one system doesn't really talk to the other system. So if I'm currently with an insurance company here in Atlanta, if I move and I need to have that transferred, what would be the best way to do that? Is there any way that it can override a system to share it, or is it I'm just going to have to get the medical records on my own?
It's a very good question because there's no one answer depending on what your electronic vendor or healthcare organization is. And so this is actually a very, very complicated question. So I'll give an example of one electronic vendor, Epic, which is the most widely used one in the United States, now does have a tab called Care Everywhere, meaning if the other healthcare organization agrees to share their records with, let's say, my healthcare organization, they can. And I can pull it up in that tab called Care Everywhere. I would say, though, and I want to emphasize, that tab is not integrated with our system, meaning even though I could have all of the data, I can't, let's say, graph out test results like I can if it were all in one system. Like I have to still manually click, like what was the potassium in 2009 and what was the potassium in 2020, and kind of put the pieces together myself. So sometimes electronic charts can share across institutions upon request. Other times that's not possible. And what I usually do actually is I do put it on the patient, which is not fair. It is not right. I don't think what patients who are sick should be burdened with getting their own medical data. But I also tell people it is the only guaranteed way that I'm going to get it. And you are the most invested, person in this. So, for example, when someone comes to see me as a new patient in my clinic, sometimes they'll send messages in advance. They'll ask, like, can you just reach out to so-and-so's office and get the records before I come in? And what we usually tell them is actually it's best if you reach out to Dr. So-and-so's office or the medical records department if you were hospitalized and ask for that full set of records, and then bring it to me, because then I can guarantee that it won't be lost in a fax machine somewhere, in a shared clinic, and that I might never even see it, even if it does end up in our clinic somehow. Because the process is so convoluted, I do put it on patients. I also tell people now with the patient portals, bring your phone and have your login at the ready, and then we just go over things together. And so that now can be the easiest way to ensure that I have access to somebody's records.
Yeah, and I think that's really helpful. And I know, like, recently I visited the doctor and we looked at the patient portal together. It's on a big screen when I walked into the exam room. And I thought that was a great way to see, because then I know what is being put in as we're discussing it. And I also know what it looks like. So that when I want to access it, I'm not just looking at random numbers. I'm starting to understand, oh, that's what that test result is, and this is what it means, and this is what I need to do. So I thought that was a great way of combining the person, the bedside manners that have you of a doctor with the modern technology, and knowing at the end of the day, we both had that shared conversation of decision making and what's going to be best for my health, and into the future. So I think that is the step in the right direction for sure.
I completely agree. And that's what I do in my clinic too.
It's a nice feature to have. You did mention, just as you were speaking, and then throughout the book, a lot of putting some responsibility on the patient, right? So to advocate for themselves. Why do you think a lot of, I'm kind of generalizing, but the average American maybe is not always comfortable with self-advocating?
I think a lot of people just can't. I mean, I want to start there, that patients are sick. It's not fair. It's not fair that we as a system are burdening patients with this. I will give an example of this. About a year ago, I saw a new patient in my clinic who was in her late 60s and had been diagnosed with mild cognitive impairment, which is a precursor to dementia. And she came to me to establish care, and there was kind of this whole long list of medical issues we needed to address. And at the end of the visit, I wrote down the steps for her of what to do next. And of course, in our fragmented system, there are a lot of them. Blood tests are in this building, then you have to bring them to me in this format, et cetera, et cetera. And I wrote down the steps and went over them with her. And at the end of the visit, she said, thank you very much. But what are the steps? And then I went over them again. And, she said, thank you very much. But what are the steps? And by the third ask, it was like my heart was breaking, but I had other patients to see. My next patient was in the room next door. And it was like I could see fragmentation this gulf just enveloping her. And I knew she was going to fall through the cracks because she could not advocate for herself. So sometimes patients just can't. And then I would say the second thing here is historically, how patients interact with doctors. There is more of an expectation. There is more of this expectation that there is a deferential relationship to some extent. I do think this is changing. I think we now teach what's called shared decision-making in medical schools and beyond, where you're making decisions as doctors with patients, not for patients. But I think some people can also be afraid to advocate for themselves because, historically, it's like doctor knows best. And they do think that the doctor knows everything about them at the very least and all of their data. And so they can be hesitant to push back and advocate for themselves.
Okay, good. Thank you. Now, another thing that you mentioned in the book is just the kind of notorious long hours that physicians have, and that nowadays, the visits seem to be getting shorter with their patients, but the workload is growing. Do you think in the foreseeable future that will continue? Do you think that putting these pieces together with, with the fragmentation that you discuss, will that reduce hours and potentially less of a workload, or what are you predicting for the future?
My hope is that it will allow doctors to spend their existing hours on the work that they should be doing and not administrative, bureaucratic, clerical, and paperwork.
Mm-hmm.
So right now, as a result of our fragmented system, there's actually a few relevant sources of mismatch here that I write about in the book that goes beyond medical records, that create this result where doctors are spending so many of their hours doing clerical work and bureaucratic tasks. So one is the medical records. We've talked about that extensively. I won't harp on that piece. Number two, though, is that this work has not been historically delegated between different members of the support staff in healthcare to the extent that I believe that it should, where most of this clerical burden, let's say in primary care, often falls on doctors' shoulders to be putting the pieces together. And we haven't reached a state of truly team-based care where we have trained medical assistants, whose role it is to be doing this work. If the computer system can't do it for us, I think, again, ideally, we would reach a state where the computer system is doing what it's supposed to be doing, which is connecting pieces that are already there. But in the absence of that, we do need humans. We need support staff. And then another really relevant mismatch here is how medicine is financed. And without getting into the weeds too much, most healthcare organizations in the United States still operate according to a basic payment model called fee-for-service, meaning doctors or organizations get paid based on services they provide. What is a service? A service, let's say, is a joint injection, a round of chemotherapy, or in primary care, it's the office visit. It's the face-to-face visit with a patient. What that means is that nothing else counts as compensated work. Not getting the records in advance, not clicking through the charts and putting the pieces of the records together, not charting that story that then you collect during the visit into a note that you're writing down for other providers to look at. And so as a result, doctors' schedules are stacked with face-to-face visits during the day. Let's say if you're in primary care from 8 to 5. And then when does all of this other work happen? It happens after 5. Doctors take it home with them. And so doctors are doing, it's actually about 5+ hours of computer tasks for every 8 hours seeing patients. Wow. So they are taking hours and hours of work home with them. And again, this is not the work of being a doctor. Like, this is clerical work that just needs to get done for the system to function. And so I am hopeful that we will get to a place where doctors' hours are just spent on the tasks that actually matter. But in order to get there, realistically, this is where I can be a little bit pessimistic. A lot of things do need to change. And I would categorize them into 3 categories: tech, team, and time, which I just talked about. The tech needs to improve. We need better team-based care. And we need just more time to spend on the patient visits that actually matter, and then not doing all of these other clerical tasks.
Right. And have you had the opportunity to look at other systems that maybe around the world that are working more efficiently, or to take tidbits from each of them? Have you had that opportunity?
I wish I had written about some other systems in the book. And the truth is that I did not go in detail, and I have not researched this in detail. But I do know about other systems, such as in the Netherlands, where they have fully connected, interoperable. Interoperable means that it's fully integrated and connected medical records that it just make the lives of patients and doctors better.
Yeah, I'm going to suggest, I'm going to give you advice. I'm going to suggest that you do that just so that you can take some trips, internationally and observe this, take a little break from it.
I pictured some people outside of this country reading this book and just, shaking their heads, being like, we solved this problem a long time ago.
Yeah, it's
And so this book is very specific actually to problems in the American health
system. Right, right. And I did very much enjoy the book. I know a lot of people think, oh, if it's kind of nonfiction, it might just have some dry facts and things, but I found your writing very easy to read. You made it very personable with your narratives of different patients that you had. And I love your analogies that you use throughout the book. I really found those very realistic and easy to understand. You intertwine it with solutions and things that American patients need to know, to advocate, and what to look for. And I do highly recommend everyone to read it and gain a lot of information about how the healthcare system works, as well as what are some positives and what can we do to move forward and making it better. So Dr. Yurkiewicz, I'm going to switch over to our audience, and if they have any questions, I'm going to read their questions, and we already have one in there. Anyone else that would like to add a question, please feel free in the chat or the Q&A. So this question is from Elizabeth, and she has had the opportunity to read the book, and she enjoyed it very much. She says, I'm actually conducting an analysis on physicians who treat Medicare and their ease or access to EHRs. I know physicians are required to do specific things with Medicare patients. I believe this is part of a meaningful use. Do you think these requirements could result in more fragmented EHRs for Medicare patients due to administrative burden?
That is a great question. And just to define it for everyone else, EHR is electronic health records. So I think what the question is getting at is what I think of kind of the balance between the benefits of checklists and standardization versus the downsides. And with Medicare patients, what the question alluded to is, for example, when I see a patient on Medicare, Medicare pays for me to kind of run through a list of questions with them. Have you had a fall in the last year? Have you taken any opioid medications in the last year? I do a little cognitive assessment to assess for memory issues. I ask if they have an advance directive, or if they want to learn more about that. And so there is a checklist that Medicare will pay for during these annual visits, because the idea is most patients over 65 would benefit from this. I think there is some truth to that. Things come up when I run through my checklist. An example is that I have ended up sending many patients for hearing evaluations, because part of the checklist is, do you have any trouble with vision or hearing? And I might not have just asked about that otherwise. If it wasn't part of the checklist, I might not have brought it up. Definitely, though, I am worried about the downsides of this. I am worried about the downsides of kind of cluttering up the charts with things that end up not being relevant to the patient's overall story. And I see these metrics, as kind of analogous to some of the ones that I mentioned earlier with meaningful use when it first started in 2011, documenting things like smoking status and end-of-life care, regardless of the reason that somebody's coming in. And so a Medicare patient might be coming in there's just one issue that's completely on their mind, and you end up running through the whole checklist. And by the end of the checklist, you have 3 minutes left in the visit to go through the important thing that's on their mind that they're there for. And so, I am I think there's pros and cons of these sorts of checklists and standardization. I do think the downside within the electronic systems that we have is that risk of clutter. It's just that risk of repetition and more clutter and burying things that are important, while some of this less important stuff you just have to document it because the insurance companies require it. And then if you're another provider looking for something about your patient, you might not be able to find, that one thing that you discussed in the 3 minutes that was most important to the patient.
Okay. Thank you. So as others might be putting questions in, when you speak of finding, I know we've talked a lot about the data and trying to access that. What do you think is the easiest way? Like in your mind as a physician, you talked about paper copies, obviously was not easily accessible either, but in your perfect world of having the data, what makes it accessible to you? What features would it be beneficial to you?
So first is fully interoperable. And that word means that data is shared between different healthcare facilities, but it's also integrated, meaning if it's one test result, let's say a potassium level, it's not located in different tabs throughout an electronic ecosystem that you're clicking, trying to put it together. So all of the relevant information is grouped together where it actually belongs. And I believe patient notes, should be written more like a story. I often get the most from another doctor's note from 1 or 2 or 3 well-written sentences that capture a lot of the relevant data, like an elevator pitch of that patient, than clicking through these dozens of different tabs and trying to recreate that narrative myself. So I think in an ideal system, it would all be there, it would all be shared, it would all be integrated in a way that then you can access if you want more information beyond that story. But I think there should be, like a front page, a storyboard where there's 2 or 3 sentences are there, with all of the relevant information intact. One thing that I will add that I didn't touch on as much earlier is just the redundancy in the charts as well as it stands. So I cited a study in my book that it's actually 60% of doctors' notes are redundant to the previous note.
Wow.
So it just creates more of that needle in the haystack, right? And so in my ideal system, of course, we would just get rid of all of that noise. And we wouldn't have to document the same things every time. And so we would just have a front page, a storyboard. And on that storyboard, there wouldn't be redundancy either. Right now, there's a medication list at the top of the chart. There's a medication list at the side of the chart. There's a medication list at the bottom of the chart. And it's very confusing to figure out which medication list to click. And maybe it might only be updated in one place and not the other place, which is very wild.
That is very
It is. And so mistakes can happen from just really simple things like that, like clicking on the wrong medication list tab. So yes, my ideal system would eliminate all of that. And the part I would just emphasize one more time is that we have the technological capabilities to do this right now. I mean, look at just any other system. Look at how your emails are organized. We can just import some of those ideas that we apply to any other sphere of tech into the electronic charts. And I think there is a lot of potential to just clean up many of these messes.
right. We kind of put, lack of a better analogy, but a Band-Aid on it to fix one problem, but we really haven't solved it, right? Just it's been kind of a temporary, and we'll add another feature to the patient portal, or we'll add another click here or there, but that hasn't solved the easy access that is so needed to perform and to make decisions. As you argue in throughout the book, is knowing that patient's true medical history, their story of what brought them there today. It wasn't just this one high blood pressure incident. There's probably many other factors, and that is surely essential to making those life-saving or prolonging a healthier life decisions. So yeah, definitely a lot to think about and how to incorporate that into effective data access. A big part of the problem, right?
Yes,
All right.
100%. I mean, I made the book narrative driven intentionally because all of these issues, they're not just dry statistics. These are affecting people every day. And I believe this is just such a root cause of what goes wrong in our healthcare system. And it's a root cause that actually has a solution. And so we need to be talking about this and giving it the proper attention compared to all other problems that we always talk about in the healthcare system.
Right. And how do your colleagues, are they in agreement with you overall, that, or are they finding other workarounds to it, or what are their feelings?
Everybody has their own creative system of workarounds. I think everybody's frustrated by this, and I cite a lot of data in the book that supports this. And then anecdotally, everybody knows this. I mean, I think everybody is frustrated with the electronic medical records. Everybody's frustrated about the time constraints and the lack of follow-up with our own patients. And everybody figures out some workaround. You know, I talk in the book about me sometimes carrying around these pieces of paper and 4-color pens, even when I'm sitting in front of multi-billion-dollar software company, because I can be more organized there than in the chart. And so, you know, we come up with a way, because people in healthcare are good people, you know, and I think they want to take care of their patients. And so they figure out a way, even if it's not the most efficient way.
Right. You're problem solvers, and you're going to solve that problem in whatever means necessary.
Mm-hmm.
Right. All right. Another question came in regards to multiple providers taking care of a patient in a particular hospital stay. What would you suggest for better communication between providers and treatments?
I love that question so much, because we didn't talk about it a lot so far. And it actually, I devote a whole chapter in the book talking about specialization and subspecialization resulting in situations where the whole of a patient's narrative might still fall through the cracks, even if every specialist is perfectly managing their slice. So I will give a brief example that comes from the book, and then give some tips for better communication. So once I was taking care of a patient in the hospital who had leukemia, and the biggest issue actually was something brewing in her lungs, where she had these persistent white patches, her oxygen levels were dropping, and I had to have a frank conversation with her about whether she would want to go to the ICU and be put on a ventilator if we couldn't get to the bottom of why this was happening. And 3 teams of doctors were on the case. And from each team's perspective, everyone was thinking perfectly logically. So from the infectious diseases doctor's perspective, we had already treated her for the vast majority of things that could cause these white patches in the lungs. We treated her with broad spectrum antibiotics, and they weren't working. So throwing on, you know, just more treatment would be like throwing spaghetti sauce at a wall, and it wouldn't work. From the pulmonary or the lung doctor's point of view, she had already undergone one procedure called a bronchoscopy that tried to diagnose what was going on, and it came up negative. It didn't show what was going on. So doing another bronchoscopy, you know, would put her through a procedure that was risky with little benefit. And then from the hematologist or the blood doctor's point of view, there was nothing we could do to speed up the recovery of her immune system. And so 3 reasonable narratives added up to an unreasonable conclusion, which was actually staying the course. And so in the book, I tell what ultimately happened, which is where I decided to treat this patient empirically for things that were considered very, very unlikely from every team's point of view. And she actually got better. And I don't share that story to toot my own horn. I think every doctor has been in the situation where they've been that specialist, just thinking through that lens. And you still might kind of miss a larger narrative. And so what I would encourage everyone in the healthcare system to do is push those different teams to communicate with one another, because that doesn't always happen. And that's another thing that I think patients take for granted when they're in the hospital, and they should take it for granted. The expectation is that if you have different teams of doctors on your case, those different teams of doctors are going to be kind of reconciling their different narratives and putting it all together. This is another situation where I would say, unfortunately, I would put this on the patient too. I would say if you are a patient and you see this isn't happening, it is perfectly okay and acceptable to ask for something called a team meeting, where your different teams of doctors come together during one meeting. So everybody is just literally in the same room and everybody can reconcile their different narratives. And that happens sometimes, but we often have to push for it because people have such different schedules and different vantage points. And so from either the healthcare workers or the patient's point of view, my advice would be to push for that team meeting if you see it isn't happening. And then if you're not in the hospital, I would also say it is perfectly okay and acceptable as a patient to ask your doctor to reach out and communicate with your other doctor. You know, like my cardiologist says, maybe I shouldn't be on this new medication. Can you reach out and communicate with them directly about whether this is the right move? It's much easier for this to happen if everyone's in the same healthcare organization. It's harder if the other doctors are outside, and you're never going to get a phone number. You're never going to be able to reach somebody directly. But all of that is to say, I would encourage and empower patients to advocate for that direct communication if they see it isn't happening.
Great. Thank you so much for sharing that information with us. So I wanted to thank you, Dr. Yurkiewicz, so much for taking time out of your extremely busy schedule to speak with us. I know a lot of people gain good information. And again, I do recommend getting the book here at Gwinnett County Public Library or your local library or bookstore, Fragmented. And it's a very resourceful and interesting book that Dr. Yurkiewicz has written. So don't
Thank
see
you.
any other questions, so I think we'll wrap it up there.
I really appreciate the time and your questions in this conversation.